at Seoul National University, Department of Periodontics. He is the editor-in-chief of implantology. He's an expert council member in the Osteology Foundation and an ITI fellow in the ITI Foundation. He's also a first-time prize winner in the clinical research at the 2019 Osteology International Symposium and has authored 90 publications in peer-reviewed international journals. Professor Ki, we are very pleased to have you with us today.
Okay, thank you so much.
안녕하세요, Professor Ki.
안녕하세요. Okay.
Before we begin the presentation, I have a little reminder to our participants. If you have any question during the presentation, please type them into the chat box to Professor Ki-Tae. Jika terdapat pertanyaan, silahkan langsung diketik dalam kolom chat saat presentasi berlangsung atau dapat memakai opsi raise hand di akhir presentasi. Professor Ki, you have 45 minutes for your presentation, followed by 15 minutes of the discussion session.
Okay, I'm having bad connection right now. Can you hear me? Can you hear me? Okay, hello. Wait, is the connection okay? Hello?
We can hear you, Professor.
Wait, hold on, just a minute. Okay, is connections good?
To our participants, please be patient. There's a little technical issue.
Yeah, okay. Is the connection working right now?
Yes, we can hear you.
Okay, okay, good. Okay, I'm gonna. Okay. Hello, Indonesia. I'm Ki-Tae from Korea. This is such a big honor to me. I would like to thank Dr. Sunarto and Dr. Sutamaya and the whole organizing committee and Dentium, of course, for the kind invitation, and hope everyone is safe and well. Okay, so the title of my presentation is How to Increase Healing, the history of open healing, how it started, and also the general procedure of ridge preservation with collagen membrane, also how to improve predictability, and also ridge preservation in compromised sockets, whether it's single or multiple. And also I would like to begin with the definition of preservation and augmentation. Clinically, there is a difference. Preservation is much easier than augmentation. Because of the presence of bony walls and soft tissue support right after tooth extraction. And augmentation can be defined as increasing the ridge volume beyond the skeletal envelope existing at the time of extraction. So there is a little difference between the two terminology. However, clinically, I want to stress that preservation, because of the soft tissue and hard tissue that is present at the time of extraction, is much more simple than bone augmentation. So this is my protocol of a ridge preservation procedure. You start by atraumatically extracting the teeth. And then following that, you debride the area very thoroughly. And then you graft the area with the material of your choice. And then you finish off with a collagen membrane for coverage at 2 weeks. And then a good ridge at 4 months. I think this is a very successful case of a ridge preservation procedure. And I used the open healing technique with a collagen membrane. And I wanted to start with the history of open healing technique. And just to explain to you about the history of open healing technique, it dates back to late 1990s when Dr. Barty et al. Published these two papers, which used highly dense microporous PTFE membrane instead of ePTFE membrane in socket preservation procedures, and then leaving them open to healed with secondary intentional healing. And then we come to the first reports of a resorbable collagen membrane that was introduced by Lekovic et al. But the surgeries were performed with primary wound closure, and then where socket preservation. Wait, just a minute. I'm sorry. So for Lekovic, it was surgeries were performed instead of secondary wound closure. It was performed with a primary wound closure by Dr. Daniel Kadaropoli, where socket preservation was compared to extraction alone in 41 patients. The experimental group receiving bovine bone mineral plus collagen membrane, and then leaving it open showed better resistance to horizontal and vertical resorption compared to unassisted sockets. And I think this is a very good data showing the promising results of open healing technique. And then we come to this study by Dr. Barone et al. In 2014, where the flapless open healing group was compared to the flapped wound closure. And then now we come to today's topic. How can we improve the predictability of these procedures? So I think the first method would be to use a biomaterial that is biocompatible and pressure resistance. So I guess this is the matrix type of bone that is volume stable, and has the structural integrity and also better handling. And then you could also improve the tailing to the defect. And I call this matrix type of bone. And I think for compromised extraction sockets, this type of matrix type of bone is like an iPhone. When iPhone first came out to the market, I think it was a revolution to the cellular industry. And for ridge preservation procedures, I think this is also, this has the same concept. And I think to improve the predictability, we could use these type of matrix type of bone. And the products that are in the market that is available is Bio's collagen. And then from the Dentium group, we have the Osteon 2 collagen. It's a mixture of hydroxyapatite and beta TCP. And then we were adding a type 1 collagen to this material. So we have that available from Dentium also. Then I just want to show you this case on number 14, where there is a recession, and also this area was indicated for ridge preservation procedure. So what we did was we extracted the tooth dramatically, and then we are using this type of matrix bone. We could customize it and just fit it into the defect like a cube sugar. And And then over this, this biomaterial, we are using a collagen membrane to cover it. And then because of the soft tissue deficiency, there's too much soft tissue deficiency, we decided to do a connective tissue graft simultaneously to make up for the compromised soft tissue deficiency. And then these are the results after the surgery. And then we have a nice fat ridge after 4 months. And I think this is a nice healing. And then we placed the implant after 4 months. And these type of matrix bone, I think, could be utilized very efficiently in this type of very compromised defects. And I think this is one way to really start to be efficient in these type of treatment procedures. And when you compare before and after, I think there's a drastic improvement clinically when you compare to the left side. And I think the patient was pretty satisfied. And then this is the healing after 1 year, after the implant placement and after the prosthesis delivery. So my personal preference is to use the collagen membrane that is non-cross-linked. I think Dentium comes up with the cross-linked collagen membranes. However, there's some properties I would like to introduce you with the non-cross-linking collagen membranes. And I think this is one of them. This non-cross-linked properties that enable the membrane to stretch, I think, is really important for optimal wound stability. And then also, it has a bioactive role in attracting important cells for regeneration. And here are some studies from Dr. Thompson's group in Gothenburg. And I think these are very critical papers that show the efficiency of these type of collagen membranes. And this paper by Dr. Turi and Dr. Elgali, and also Dr. Omar, proving that collagen membrane is not passive, not just passive, it's actually embedding growth factors from surrounding tissues and secreting factors that are responsible for faster bone formation and remodeling. So I think this type of collagen membrane has a very active role too, not just a passive barrier function, but it has these active role that for participating in bone regeneration and tissue regeneration. And then here, I wanted to show you some cases of ridge preservation with open healing. We're using the non-cross-linked collagen membranes. Okay, we can see that the socket entrance in the 3 groups are quite large when you look at the 3 cases. It's quite large, but I would like you to note that quick epithelialization is achieved at 1 week, and also complete closure of the socket at 30 to 60 days. This is quite elegant, I think. This is very nice healing. And we could see the socket entrance covered with epithelium almost around 1 month, 30 days. And to summarize the results from this study, the flapless ridge preservation group showed less horizontal resorption and more keratinization in the study by Barone and al. So in the socket entrance where it was left for healing, we could see that the width of keratinized gingiva and also the bone width, actually the flapless ridge procedure was showing much better results in this area. And then I want to come to this paper. It was recently published by Dr. Thoma et al., the Swiss group, published in COIR in 2020. I think following this period, there were some questions about soft tissue that was forming in these areas where ridge preservation was done with collagen membrane. And I was always curious how much soft tissue thickness we would gain from open healing. And we finally have an answer from this study. And the results show that in the area where open healing was attempted, a 3 millimeter thickness of soft tissue was formed at the ridge crest after 2 months. So when you do a open healing procedure with a collagen membrane, we are able to get 3 millimeter thickness of soft tissue. And I think that's quite remarkable. That's quite remarkable. And that shows that gives you some confidence in this type of open healing. And then I want to come to the use of some, I guess, instruments that would enhance the ability to debride the area very thoroughly. And this is the type of instrument that I'm working with Hufridi at the moment. It's called the Claw. I think it should have been out a year ago, but because of the pandemic, the release date has been postponed 1 year now. I think we're in the process, but when we look at this instrument, it has serrated ends at the end. Also, it has the bone file features, and it's much more, I guess, efficient in removing the granulation tissue. And I think if we are comfortable removing the granulation tissue and the infection source right after extraction, I think that would really enhance the predictability also. So yeah, we are expecting this to be out when probably the pandemic is over, but we have very high expectations of these type of instruments. And then I want to cover a little bit about debridement, because debridement is very important, I think very important. And I'd like to show you a video. I hope it gets through. Okay, it seems to be working. So we first start out with a surgical curette. And then now we are using hemostats. And then in cases where hemostats, if you need more rigidity, I think bone rongeurs could be used to rip out the granulation tissues. Remember, we have to see that this is the same case, same patient, and we're spending a tremendous amount of time to debride the area. And then finally, we are finishing off with the blade. And then we are finishing off with a smaller surgical curette to actually create some intentional bleeding in this area. Okay, so I wanted to stress about the importance of debriding the area very thoroughly. Okay, in these type of ridge preservation procedures, when we are extracting the tooth, and then when we are immediately doing these type of ridge preservation procedures, we need the area to be thoroughly debrided and infection-free. So first we start out with a big surgical curette, and then I don't think in some cases where the infection is very acute, that is not enough, because the granulation tissue and the inflammatory tissues are very fibrotic. So it becomes attached to the bone or the soft tissues. So we have to remove that and then sometimes we have to rip it out with a hemostat, or when you need more rigidity, you might use the bone rongeurs. And then in some cases, you have to use the blade to remove the granulation tissue. And just to tell you, I spent a lot of time doing the disinfection in this area to remove as thoroughly as possible. And then in case some of you may ask me if it's safe to do ridge preservation immediately following extraction, our answer is yes, because, and we use our study as a reference. This is a paper that was published in 2017 in JCP. And then we go back to look at the data, okay. 307 patients who received ridge preservation procedure in our clinic. And this is, I have to tell you, these were compromised extraction sockets. There was acute infection. And then we debrided the area very thoroughly. And then we performed the immediate ridge preservation procedures. And we only had 2 infections in this area. So the cumulative success rate was 99.35%. So that's quite convincing. So I think it is fair to say that these type of procedures are pretty safe. And I would like to tell you that it's much easier if we have the flaps right after extraction. When we utilize the flaps as a barrier, I think the procedure is much more simple. And that's why we want to do it immediately after tooth extraction. Okay, so I think that's the second method, debriding the area very thoroughly to increase the predictability. Now we come to, okay, another study that was published in JPIS with Dr. J.C. Park, a good friend of mine. And this is about hidden neck suture. So this is a clinical study comparing the efficacy of hidden neck suture compared to X suture. And I just wanted to explain to you that hidden neck suture is a type of suture that does not give tension to the area, the opening of the extraction sockets. So it does not create tension in the middle area. And I think this is very important, because I think it's important for the better stabilization of the graft materials. And also it's showing much better results compared to the conventional X suture. So just to show you briefly how to perform a hidden neck suture, you start at one point, and then when you're going diagonally, you go underneath. So that's why it's called the hidden X suture. And then when you're going parallel, you don't want to give tension to the middle area. So you are literally passing the interdental area to minimize the tension in the socket entrance. And then you go in this way, you come back, and then you want to spread out this area so that when you are tying it to the initial entry of the suture material, now again, you are not giving any pressure to the middle area. So this is the secret of hidden neck suture. And then just to show you a quick video of how a hidden neck suture is done, you start at one end, and then you want to go wide so that you don't want to give any tension to the middle area. And then you come in again. Anything you are going diagonal is underneath. So it's hidden inside. And then you're going as wide as possible. And then you're tying it to the initial entry. And now you have two parallel sutures that are parallel, but also avoiding this middle area, so that this middle area has no tension. And this is really important, because when you look at the hidden X suture above and the X suture below, it's quite clear that this area has not been affected by the tension. And when you look at the X suture below, you know that there is a divergence, or the the tension is actually collecting, and this has an effect later on because the width of the preservation bone area could be affected later on. And then when you look at the results of the study, when we compare the width of keratinized tissue, hidden X suture has significantly prevented the shrinkage of keratinized tissue. Also, very interestingly, even the bony horizontal dimensional change was significantly smaller in the hidden X suture group. So we are actually showing, and also better results for the vertical changes in the alveolar ridge. So I highly recommend hidden X suture compared to the X suture when we are doing these preservation procedures. And okay, this is an area that was grafted with DBBMC. And then we are doing the conventional X suture. And we know that after the X suture, there's a vector that has been created in the buccolingual direction. So, and you can see that the mucogingival junction is severely shifted to the lingual side. So this is what we want to avoid, the tension that is created in the entrance of the socket to have, okay, maximum bone width and also maximum width of keratinized tissue after the ridge preservation procedure. Okay, so yeah, these are the final results, and we placed the implant. So we have a minimized or jeopardized area of keratinized tissue, and this is what we want to avoid. And I think by utilizing the hidden X suture, we are able to do that. Okay. Okay, so far so good. Now we've talked about the suture, also debridement, and ways to increase the predictability. Another way is to have a better understanding of extraction sockets. So when we talk about extraction sockets, we know that there are fresh extraction sockets and also there are compromised extraction sockets. And compromised extraction sockets are a little more complicated. So now I would like to spend more time on the limits of ridge preservation with open healing. So, okay, as you can see in the slides here, not all sockets are the same. Some may have more destruction, and some may even have no walls remaining, like the socket walls you're seeing in the slides. So we decided to call these type of sockets compromised extraction sockets, and I'd like to spend more time to share some of our experiences with compromised sockets, where our group has been exploring for some time. And then this is a study that has just been accepted, and we tried to propose a classification system about compromised socket that include all possibilities of hard and soft tissue loss. And when we have a better understanding of these type of sockets, I think that could increase the predictability also as we approach these type of procedures. And looking at the prevalence in the data, we found that simultaneous buccolingual wall loss, whether it's greater or less than 50%, made up 87% of all the sockets. So type 4, I think the prevalence was almost 87%. And another study, another randomized control trial that was published by our group really shows about the characteristics of these type of compromised sockets. This study won the first prize in the Osteology International Symposium in 2019. And it has just been published in JCP also this year. And the title was, "Is Ridge Preservation Effective in Periodontally Compromised Extraction Socket Randomized Control Trial?" And I just wanted to explain to you that in this study, we only included compromised extraction sockets. So that includes decents of greater than 50% of socket heights. In the test group, they received extraction plus ridge preservation with DBBMC and a collagen membrane. The control group received nothing. So extraction and spontaneous healing. And then this is the analysis we did: soft tissue, hard tissue, and bone core biopsies. And like I told you, matrix type of bone was used in the study. Okay, just to repeat that. Okay, this I'm going to skip. And just to show you the results of the study, because of the time limits, I just wanted to show you the results from the spontaneous healing group. Okay, the yellow line is before extraction, and the blue line is 4 months after extraction. And when you overlap the two, we could see that there is a lot of resorption in the buccal area, okay, compared to the lingual area. So in the spontaneous healing group, we lost a lot of bone, especially on the buccal side. And when we look at the ridge preservation group, we could see that actually there was vertical gain in the ridge preservation group. However, when we look at it horizontally, we lost a little bit of bone horizontal dimension, especially 1 millimeter below the CEJ. But when you compare this to a control group, I think the results were significantly better in the ridge preservation group. And when we look at the soft tissue also, when we compare to ridge preservation to spontaneous healing group, I think the ridge preservation group did much better, okay? Lost about 1 to 2 millimeters compared to 3 or 4 millimeters. And then when we look at the histomorphometry, this was quite remarkable. When we looked at the new bone formation, even in the control group and the test group, there was 31% of new bone formation in these type of compromised extraction sockets. So very compromised situation, and we have 31% of new bone formation. I think that's quite remarkable. That's quite remarkable because we know that from the beginning, we lost a lot of buccal and lingual wall also. So it was compromised to begin with, and then we're stuffing a lot of biomaterial inside these compromised sockets. And I don't think we expected this type of good results. And 31% of new bone formation, I think, was quite exciting for our group. And we were very happy to see these type of results. And then after the RCT, we have decided to write up a case report in our group with the most severe destruction in single sockets, I must stress, and show the histology as well. And here are the cases at baseline and 4 months when you compare the two. The case you see in blue are the cases before extraction, and in brown are the ridges 6 months following extraction and immediate preservation. And these are the results. I would like you to see the beautiful histology obtained with the biopsy cores, and nice results at 4 months, even in these type of very compromised situation. And then here's another case. You can notice the architecture and the walls. The walls have been lost prior to extraction. Now it has been re-sculptured, and the flaps, I think, probably served as the barrier here. And now you have new bone formation and then new morphology of the socket. And when you look at the biopsy, you can see new bone formation in this area too. So very interesting, very exciting. Another very severely destructed case here. You could see the architectural rebuilding, I must say. You could see the dot lines when we connect the black dot lines and the blue dot lines. These are the areas that have been created through this ridge preservation augmentation procedure. And looking at the histology again, we are seeing new bone formation in these type of very compromised situation also. So very exciting. Okay, now coming to the final part of my presentation. Now we know that ridge preservation may be highly predictable in single extraction sockets, regardless of the severity of destruction. Now, we just want to expand this principles. Can this principle be applied to multiple extraction sockets? And our group has been working on this also. And if we understand the socket biology, whether it's single application or multiple extraction sockets, I think the understanding and knowledge really would enhance our predictability as we perform these type of procedures. And I'm still very cautious about this, because to expand this into multiple extraction sockets, and we're not talking about heal sites. Okay, these are not heal sites. I'm talking about extraction sockets. And I don't want you to get the wrong idea. However, when you look at this case, this was the very first case, and see that in a week, we could see very rapid epithelialization in this case. We're getting nice coverage and epithelialization in 1 week. And when you look at this phenomenon, maybe. So our group has decided, so we are working on the project, as well. And we are trying to expand this into multiple extraction sockets. We're in the very primitive stages. And the first case I would like to show you, we use the dentium collagen graft as a collagen membrane. And just to share with you some of the cases, this is a case of preservation augmentation performed with DBBMC and a collagen matrix. And here we extracted the tooth, debrided the area thoroughly. We used the matrix type of bone to augment this area. And then with open healing, we did interrupted suture and left it to heal with secondary intentional healing. And then this is the healing you see at 1 month. Okay, so the healing is quite nice. Okay, after 1 month, and we could see that the epithelialization is quite quick. We could achieve epithelialization within 4 weeks, and I think that's quite remarkable. And we do get the nice thick ridge. When you look at the horizontal and vertical dimension, we do get the nice thick ridge that was anticipated when we did the surgery. You can see that the horizontal width was saved from resorption, and 2 implants were placed into the sites, okay, 8 millimeter long, and I guess we finished this case with the implants. Okay, another case, I think we are seeing 2 fractures, so we decided to remove the 3 implants that are up front and leave the one in the back. And then what we decided to do was, after removing type of bone, just to overbuild this area. So like vertical augmentation, we used the matrix type of bone to create like a camel hump, the back of the camel. So we made a hump in this area, and then we used the collagen membrane that is expandable. So we stretched it, and then we're using the mattress suture to tie it on one end, and then we are actually stretching it to the other end. And then we are using 3 interrupted sutures to finish this case with a open healing. And the results is quite astonishing, actually. This is, I think it was 1 week after healing. This is a very nice healing with the non-cross-linked collagen membrane. And then the second slide shows results at 1 month. And then we have the results at 4 months. And then we placed a implant in this area. And actually, the first implant was very close to the nerve. So that's why we tried to augment this area vertically with the matrix type of bone. And I think we were quite successful. We used a 8 millimeter long implant to place the implant. Okay, this is Superline 2 by Dentium. And then we finished off this case. So Yes, multiple extraction sockets with open healing was quite successful in this case. I think this is the last case I will show you. Okay, this could be a little tricky, okay? It's a combination of extraction sockets and a heel ridge. However, we decided to augment this area anyway, just to see how it goes. And then we used the matrix type of bone. And then in the next slide, we used the collagen membrane, stretched it to the other end so that it was actually expanded and stretched when it was tied. And then we used multiple interrupted sutures to create a very big open healing case. And when you see the results here, it's quite remarkable. At 7 days, we are showing signs of epithelialization. And then again, in 30 days, we were able to get the full coverage of the open area with a nice epithelium that was formed. And then this is the ridge at 4 months. And then we decided to do a guided surgery with the Dentium guide. And then we placed 3 implants. We originally planned to place 4 implants. However, the patient had some financial issues, so we decided to just place 3 implants. And then this is the healing with the implants, the healing abutment. Okay, and then we have the nice 3 implants in, and this is how we finished the case. So before ending, another way to enhance the predictability would be to use growth factors maybe. So we have been doing some research, and we have been working with hyaluronic acid for about 5 years now, and we are seeing very, very promising results. However, we have not transitioned to the human trials, but we have data in animals, in dogs, and it's very, very promising, very, very promising. And I know that Anton Sculian, Dr. Sculian is also working with hyaluronic acid. So I think in the future, if we utilize these type of growth factors, I think this could really help in promoting open healing in compromised sockets. Also, we are working in soft tissue growth factors as well. This could really help speed up the epithelialization and also create a better soft tissue healing environment. And I think if we mix these type of growth factors with our knowledge, if we have more knowledge, I think we'll have a better future doing these type of procedures. And I come back to the title, How to Increase the Predictability of Ridge Preservation Augmentation Procedures. And just to summarize, okay, we have talked about biomaterials, okay? So utilizing the matrix type of bone, and also there are different types of collagen membrane out there, okay? My personal preference is the non-cross-linked collagen membrane. So I think this could help to enhance the predictability. Also, infection control I've talked about. So, okay, we have to spend a lot of time for debridement also, but there are new products, new instruments that are coming out to actually make this more easier and efficient. So please wait, okay? I think the Claw will be coming out after the pandemic. Now we're also looking at the suture techniques, okay? The hidden X suture, okay? We're working on mattress sutures also to stabilize the matrix type of bone, and then to minimize dead space. So I think in the future, there will be improvements in the suture techniques also. So this could be an edge to improve the predictability. And then understanding the biology, I think that's very, very important. So about the incidence rate and also how it heals, the healing concept. So I think understanding the socket biology, also about compromised sockets, is very important. And then we finish off with the growth factors. So I'm almost at the end of my presentation. Okay, to summarize the findings of my presentation today, okay, rich preservation, augmentation with open healing can be quite promising and predictable, even in the most challenging single extraction sockets. So I would say in single extraction sockets, these type of rich preservation augmentation procedures is quite predictable. Now, the use of DBBMC with collagen membrane, I think it may be a good approach. However, we know that it's also very expensive, okay? We know that these products are very expensive. So now we can use other products as well. Some of them are less expensive. So yeah, so I think a combination of that could actually enhance the predictability also. And then rich preservation augmentation using the open healing approach remains a challenge in multiple extraction sockets, not healed sites, by the way. So we need more data, we need more research. And however, if advances can be made to make this indication more predictable, this can be a tremendous benefit for both the clinician and the patient, because the procedure is much more simple and easier than the conventional augmentation procedures. So right after extraction, we have the flaps, we have the remaining bony walls. And before losing it, before it resorbs away, we could utilize that to make this type of procedure much more easier and simple. So we know that horizontal and vertical augmentation is a very, very difficult task. So to conclude, more data and research is needed in this area, and we are doing a lot of research about this phenomenon, and we have high hopes for the future to actually expand this concept into multiple extraction sockets. So with this, I would like to thank you for listening. Thank you for your kind attention, and thank you for the kind invitation. And 감사합니다. Thank you very much.
Thank you, Professor Ki-Tae. Now we'll enter the discussion session. That was a very insightful presentation. We have a couple of questions.
Okay.
The first question is from Dr. Mirza Aquarius. Dear Prof, if we have a type 3 socket, how do we manage preservation with bone graft material and collagen membrane to avoid the horizontal resorption? Can you give us any tips on tricks on those type of cases?
To prevent the horizontal resorption?
Yes.
After, okay.
After, yeah, for the type 3 socket.
Type 3 socket is quite unique because I'm experiencing a big howling, so excuse me. Okay, sorry. Now better. Type 3 sockets are sockets that have soft tissue deficiencies also. So in this type of cases, we need to use a matrix type of bone. Okay, I'm experiencing bad howling right now. Sorry. Wait, okay, just a minute. Let me take care of this. I'm experiencing very bad howling.
It's okay.
Okay, sorry, just give me a minute. Okay, better. So I think using matrix type of bone to have the structural integrity, also I think that is important, very important. Also, using biomaterials that are pressure resistant. So, you know, biomaterials that won't resorb that easily, okay? So it will be resisted to some type of resorption properties. I think utilizing that type of biomaterial is important. And also compaction would be very important too. When you compact these type of biomaterial, especially when you're using matrix type of bone, you increase the density also. You increase the density. So that really helps too. So we could use that. So yeah, so I think the choice of biomaterials could really help fight the horizontal resorption. And then I've told you the type 3 is quite unique because it has the soft tissue deficiency also. So in these type of cases, you have to augment this soft tissue at the same time, simultaneously with the hard tissue preservation plus the soft tissue augmentation, and then you'll have a predictable outcome or a nice outcome. And yeah, that is my answer. Okay.
Okay. Yes, thank you. The next question is from Dr. Lilis Anggarwati. She asked, when we use collagen membrane, what type of suturing technique gives the best result?
I think the one I've explained to you, the hidden neck suture.
Hidden neck,
yeah. So if you need more information, I think there that has been published. So it's very straightforward, and really, if believe me, if you use that hidden neck suture, it's really to keep the width of the bone and also the width of the keratinoid tissue, and also it doesn't what do you call it? It stays in place for a long time. So it's very stable.
Stable, right? Okay. Okay, we go to the next question. This is from Dr. Adit Widaryano. He asked, in cases of perio-compromised sockets and also compromised soft tissue, such as recession, will it be beneficial if we apply CT graft also, just in hopes we can gain volume and also thickness?
Yes, but I think that only applies to the anterior area where aesthetics is important. When we talk about the molar area, where I think function is more important, I think we have to think about that a little bit. Yeah, but because yeah, we don't want soft tissue. There is patient morbidity when we remove tissue from the hard palate. So, and there is research right now about using the collagen matrix that we can use instead of our own tissue, and I think that could be a little promising in the future. But I think when we come to the question, it applies to the aesthetic anterior area. I think in that area, I think that's important, okay, to do a connective tissue graft and so on, but less important in the molar area where, yeah, aesthetics is a minor issue. Okay.
So, so the CT graft is more towards like aesthetic purposes, you would say.
But yeah, but the case I showed you had really it had a big recession. Yeah. So in that case, when we look at our own potential, if you just do a hard tissue graft, you're going to get collapse. Okay, you're going to get collapse of the soft tissue. So I think in some cases where the threshold has been crossed, so your own genuine healing potential is compromised. In cases where the soft tissue recession crosses the limit, in those cases, I'm saying you have to do the hard tissue and soft tissue augmentation at the same time.
Okay.
Okay.
Understood. Yes.
very compromised situations, if we use autogenous bone, I think that would really help to boost up the healing potential. I think that would help really, and also to prevent horizontal bone loss. If you add autogenous bone to these area, I think that could help prevent horizontal bone loss that occurs during the healing process. However, acquiring autogenous bone is another step that is complicated, and also it could be troublesome. So we are trying to find solutions that are easiest, more simple, and then we don't want to do multiple surgeries. We don't want to get autogenous bone from other areas. So we want to try to get it simple. So I think the best way would be to find a growth factor that could be readily available easily, that is cheap, that is inexpensive to manufacture also. And then also for clinicians globally, I think if it's inexpensive to use it, not like BMP. BMP it has many complications, but at the same time, it's too expensive. So I think if we have that growth factor in the future, and I think we will, within the next 5 to 10 years, we will have some type of growth factor. And I think that could help really. So if we have that, I think I don't think we'll have to acquire or try to get autogenous bone, from any distant areas from the surgical site.
Okay, hopefully that does come through, Prof. That probably would be a game changer. The next question, yes. I think I'll have to translate. So this is from Dr. Rico Rayanti. She asks, like in cases of mobile implants, this is a bit off topic, I guess, for some time, example like the incisor, would it still be possible to use graft and membrane for these type of cases, mobile implants? Implant that has already mobility.
No. If the implant is mobile, you have to remove it. You have to remove it.
Explant.
You have to remove it, and then depending on the defect and the ridge, the environment that has been created, you may have to do a ridge preservation even after removing the implant. So after removing the implant. So after removing the implant, if the socket is stable and it's nice, okay, I think you could go ahead and place another implant, whether it's wider or longer, that would be fine. But if you see inflammation and if you see disruption, and then it becomes a very unfavorable situation, I think ridge preservation would be an indication too. So the indication for ridge preservation augmentation is not just after tooth extraction, but it could be one after removing a failing implant or an implant that is mobile. Okay.
Thank you, Prof. Yes, we have another question here from Dr. Eric. He asked, what kind of irrigation solution that you use during the debridement process?
Debridement, just saline. So
saline.
Yeah. So I first started out with a big what do you call it? Surgical curette. So we used the bigger one. It's like when we scoop up the rice, a rice scoop. So yeah, we are scooping up from the bottom and also the lateral walls. And sometimes these inflammatory tissues are attached to the gingiva also. So we scoop up, and then if that's not enough, we have to rip it out. So we use the hemostat, bone rongeur, and then sometimes we use the blade to cut it out. So yeah. These type of
healing socket preservation. Do the material, what type of material we use in the result, and maybe you can graph material that you recommend, and also like, or are there any alternative membranes that are cheaper than the DCCMP for open wound healing?
Okay. For the biomaterial, I think when we look at the evidence, okay, when we look at the evidence and the price, I think we have the most evidence for the products that are made by BioOS BioGuide, okay, but we have the price and it becomes an issue. So if the price is not an issue, I think we could use the products from Geislich, okay, that won't be a problem. But if there is an issue for the price, I think that's too much. So I think, Dentium is a good supporter. We have products like the Osteon 2 collagen, okay? So that could be utilized also. But we have to know that it's less spongy, so it's a little brittle, okay? So it kind of breaks. But nonetheless, it works, okay? So it works. And then you have the collagen membranes that are used, that are just distributed by Dentium. And what comes to my mind is collagen graft. It's a collagen matrix called the collagen graft. So I kind of use that too. If it's too expensive for the patient, my first choice would be BioGuide, okay, but it's sometimes too expensive. So if that's an issue, we can move on to collagen graft. However, healing is not the same, okay? Healing is a less slower in the products. And then we have another membrane called the dense PTFE membrane. So I'm sure you heard of it, Cytoplast, okay? I think that could be an alternative, but that is quite expensive too. That is quite expensive too. So yes, I think really the price of these products really dictate what we choose. But if you don't have an issue with the price, then I think you could choose the biomaterials of your choice and with better evidence, so more evidence, more publications using the product. I think that would be a good choice or a good indication to use. Okay, does that help?
Okay. Yeah, very clear. Okay, we have another question here. Dr. Anastasia, she asked, for the open healing process, do the patient need to take intraoral medication or topical medication to prevent any bacteria growth or infection?
Definitely. I forgot to mention that. 1 week or 10 days after the ridge preservation procedure, we have to take systemic antibiotics, okay? And for Koreans, I think Koreans take a lot of antibiotics routinely. So amoxicillin itself has less efficiency or less impact. So for Koreans, I prescribe something stronger than amoxicillin alone. I don't know the case in Indonesia, but we need strong antibiotics, strong antibiotics that are administered, orally for 1 week, at least 1 week. So I think that's very important. And the patient would be instructed to gargle with chlorhexidine twice daily for 2 weeks.
Okay, I think that's very clear. Now we go to the next question from Dr. Ina. What are indication and contraindication for ridge augmentation?
I think I don't find that many contraindications. However, right now, I would like to keep it to single sockets, okay? Because the results are very favorable for single sockets, okay? And even in multiple sockets also, I'm seeing very promising results because I think there has been improvement in suture techniques. And also, when we graft with the biomaterial, we are actually condensing it, compacting a lot so that it's very stable inside. It doesn't move around. And then what else? The suture technique, and also uh, the uh, the stent. We could from a acrylic, we can make an acrylic stent after the procedure to keep it protected from the oral environment, from the bacteria. So I think that could be another way. So with this kind of improvement, we are seeing a lot of improvement in this area. So I don't think multiple extraction sockets would be a contraindication. But however, for healed sites, it's different, okay? But if we have multiple extraction sockets, I think it will work. And we are able to save about, I think, roughly 70% of the height. Right after extraction, even multiple cases, we are able to save about 70%, 80% of the height. So this means under the sinus and even the molar areas in the mandible, we don't need to do further augmentation later on. So even if we only have 70, 80%, I think that's good enough to place a short implant, which is an 8 millimeter. I think it won't be that difficult to place an 8 millimeter implant. And then you don't have to do a sinus procedure, or you don't have to do a vertical augmentation procedure. So I think we have a lot of advantages. Indications, I think most of the cases are good for are indicated. I don't see many. However, we have to be careful in the healed sites. In the healed sites, we have to be careful, and then need more research in the multiple extraction sockets. But yeah, but I think we are moving into that direction, and we are finding more solutions. So I think that will be the future, maybe.
We still have a couple of questions, Prof. This one is
Okay.
from Professor Rupianto. He asked, regarding sockets with different application, do you have any preference in which type of classification use which material or membrane, or in a sense for the stability?
I think for socket types that have minimal destruction, or the good cases, the cases with minimal destruction, and when you have all the bony walls preserved, those cases, I think you can use anything. So there are no limits, or there are no favorable choices in those type of sockets. However, when you look at the sockets with major destruction, then we have to think about biomaterials. And in these cases, I prefer the matrix type of bone, because when you don't have the bony wall support, it's not a contained defect anymore. You need to have a biomaterial that is resistant, so that is spongy, so that it has the structural integrity. So I prefer DBBC in this area, the matrix type of bone. And then for the protection in entrance, I prefer the membrane with non-cross-linking, so that we can stretch, and then use it. And when we look at Dr. Urban, East Urban's sausage technique, It's the same principle. It's the same principle. The only difference is he's using a tag to stabilize the collagen membrane, and then he's actually pulling it and stretching it to the other end so that you'll have and will restrict movement of the biomaterial. I think it's the same thing. So I like to use the collagen membrane that is stretchable. Okay.
Okay, the stretch property of the membrane really helps.
Yeah.
This is there's a question from Dr. Ira Fardiani. I need to translate this. So
Okay.
she has two questions. The first one is during your presentation, there was a slide regarding the thermophometry test, and in the control group, there is an empty value. What does that mean? And then the second question is the cases that you presenting a collagen brain, which ones find challenging and why?
Okay. Wait, I didn't get the first question.
Can you
Sorry.
hear me?
Sorry. Yeah. I could hear you. Yeah.
The first question.
Yes.
Okay. The first question. Yeah. Okay. The first question. In one of your slides, there's a thermophometry test, and in the control group, there's an empty value. What does that mean?
Let me go back.
Yes, and then the second question is regarding which cases is challenging from.
Let me go back to my slides. MV value. So sorry, I don't understand the first question. I think when I showed that histometry, the first was the connective tissue, the amount of connective tissue in both groups. And then the second slide was bone graft, okay? So one group received the bone graft, the other received nothing. It was spontaneous healing. So there was a comparison between the two groups. And then I evaluated new bone formation. So I think the three parameters that were evaluated was connective tissue, bone graft, and new bone formation. And of course, the control group had a better new bone formation compared to the test group. However, we have to realize that in the test group, we stuffed a lot of biomaterial inside. So yeah, this is, yeah. So I'm not sure if that answered the question. I'm not really sure I understood the question. Okay, what was the second question?
In which, from the cases that you presented us using the collagen membrane, which ones do you find challenging?
Oh, type 3. Type 3 is the most challenging situation because you have the soft tissue dehiscence also. So type 3 is the most challenging. And then type 4B, when you have no bony walls and just soft tissue. So I think type 3 and type 4B are the most challenging situations.
Because of the time limitation, I will ask one final question.
Okay.
So a couple of our participants asked, but I think we can group this to do you often use PRP mixed with bone graft material, and also do you would applying a PRF membrane for the socket or its preservation help in combination?
I have nothing against PRP or PRF, but just a personal belief. I never had the necessity to use a PRF or PRP, but I believe there are a lot of followers for PRP and PRF, so I don't want to say anything against that. But personally, I don't use it. I don't use it, and I think it's very useful because it could be what do you call it? It could be used as a glue. I think it attracts and it unites or unifies all the grafting material into one piece. So I think it has its function, but however, my personal, I never had to use that by PRF and PRP. Okay.
Okay. I think that is it for our discussion session. To our participants, or if your questions aren't able to present. We'd like to thank you very much, Professor Ki-Tae, for your time and your interesting and informative presentation. And I hope this discussion will be fruitful to us all.
Okay, thank you very much for the kind invitation. It was a big honor, and I hope everybody. Thank you very much.
Okay, I would also like to thank our participants who are staying here for kind of Dr. Siu.
Thank you very much, Professor Ki-Tae and Dr. Valio. Now we would like to present the certificate to Professor Ki-Tae for sharing your expertise in this session. Thank you very much, Professor. And the certificate to our moderator, Dr. Valio. Terima kasih, Dr. Valio. Once again, thank you very much, Professor Ki-Tae and Dr. Valio. Selamat datang kembali kami ucapkan kepada para delegasi Kongres Iperi di acara webinar ini. Nah, selanjutnya mari kita dengar